for clinical decision in the ICU. So POCUS is increasingly recognized as a critical component of intensive care practice. And nowadays, POCUS has become intensivist new stethoscope. As much like the stethoscope refines auscultation, POCUS refines our physical examination, provide real-time, immediate, and actionable information. But we need to remember that POCUS is an adjunct. It is an additional tool. It should not replace clinical examination, history, physical examination, formal imaging modalities, as well as the clinical judgment, right? Even the recent literature has shown a warning towards the pitfall or the over-reliance on the POCUS. The Jones and colleague in 2023 showed that the variability in image quality and interpretation exists even among the expert practitioners. The year before that, Berg and colleagues showed that the resuscitative POCUS may show discrepancies in the POCUS diagnosis of shock and its clinical management. And in the same year, the Duffel and colleagues showed that the discordant findings exist between the cardiac POCUS and the comprehensive TTE, and which may lead to the delayed or missed surgical interventions. So we need to remain cautious while we interpreting the findings of the POCUS in our day-to-day practice. So why we need to remain cautious? Let us start discussion with the basics first. So first and foremost important thing in POCUS is optimize your probe, select the proper probe, optimize the orientation and pointer position, because inconsistent orientation leads to misinterpretation and wrong side diagnosis, right? And that may make blunder in your day-to-day practice. As in this image, in the first image on the lower end, we can appreciate that the total depth is kept as a 4 centimeter, right? Even though the 50% of the depth, beyond 2 centimeter depth, is of no clinical use. Instead, if we adjust the depth as such that the area of our clinical interest comes in the center of the image, it will automatically improve our image quality, right? So we should make sure about the adequate depth as well as gain. Now let us discuss about certain cognitive traps in the ICU. If we are not aware about such thing, then we may make certain blunders in our routine POCUS interpretation of our images. So first and foremost is the confirmation bias. That is tendency to search for confirmatory evidence to support our provisional diagnosis. So let us understand this with a case. Suppose a patient with a known case of heart failure come to your ICU. He is already having reduced ejection fraction. He presented with dyspnea in your ICU. So clinician wonders about the heart failure as a provisional diagnosis, and on POCUS what he find? The ejection fraction is severely reduced, and on lung ultrasound he finds the B lines, right? So immediately he terminated his POCUS examination and came to the conclusion of cardiogenic pulmonary edema. So he administered the Lasix bolus, diuresed the patient, and within few hours patient's hemodynamics worsened. So why that happened? So in the evening round, the senior consultant again did the lung ultrasound in detail, and he found that on examining the PLAPS point, that is the posterior points, he found a large consolidation in the lung, right? So basically, the take home is always seek at least one finding that disprove your favorite diagnosis. And if you are not able to find that one point, then the chances of the correctness of your diagnosis is quite high, right? The next is premature closure bias. That means the tendency to accept a diagnosis before it has been fully verified. So 65-year-old male, known case of COPD, recently intubated for hypercapnic respiratory failure. Immediately post-intubation, CVP line was inserted in right IJV. Immediately after the procedure, patient developed hypoxia. Ventilator was showing raised pressures. So the on-duty registrar performed the bedside lung ultrasound on the right side of the chest. And the findings suggest absence of lung sliding, right? So the immediate thought that comes in our mind is diagnosis of right pneumothorax. So the registrar inserted the chest tube, and post-chest tube insertion, hypoxia further worsened. So ultimately they'll end up in doing the CT chest, which showed the large apical bulla. So we need to think for the other causes as well of the similar image findings, right? As in this case, the other causes of absent lung sliding includes apnea or mainstem intubation, pleural adhesions in case of post-pleurodesis, or even the bullous disease of the lungs. We also need to confirm certain confirmatory finding on POCUS before reaching the final diagnosis. As in case of pneumothorax, we need to look for the lung point, right? Next is the avoidability bias. It is a last case effect. So yesterday you diagnosed a large pericardial tamponade in a postpartum patient. Today you received another hypotensive trauma patient. So anechoic rim around the heart, right? This is a plex view, and you can appreciate some anechoic rim, right? So you instantly assume the tamponade again, right? But this is not the tamponade. This is basically a epicardial fat. So we need to confirm it with the other views, right? Do not jump to the conclusion by taking a single view image, right? Always confirm it with the other views. We need to also look for the confirmatory signs. Like for tamponade, we need to look for the systolic collapse of RA or diastolic collapse of RV. So sometimes recent or emotionally striking case overly influence our current judgment. So now let us discuss about the commonly used POCUS parameter, that is IVC, for fluid responsiveness in the ICU. These two articles has excellently narrated the various limitations of the IVC. It showed that why IVC may fail to accurately predict the responsiveness in ICU. So we all know the size of the IVC or the diameter of the IVC depends on the multiple factors. It depends on the factors that affect the thoracic pressure, cardiac function, abdominal pressure, even the blood volume, right? And there are certain physiological parameters which may affect the variability of IVC size, like the ventilator setting. Previously, the IVC in an intubated patient is only validated in larger study in the patient subgroup of who are ventilated with a large tidal volume, that is 8 to 10 ml per kg, and having ventilated with a low PEEP. But nowadays, post ARDS net trial, we all are ventilating our patient with a high PEEP and low tidal volume, right? So ultimately, it leads to the reduced variation despite patient is having fluid deficit. Similarly, the patient's inspiratory efforts, particularly if patient is ventilated with a assisted ventilation, he is on NIV or CPAP, it leads to because of his strong respiratory efforts, it leads to the false collapsibility. And sometimes if patient is drowsy, because of the shallow breathing, it shows the false stability. Similarly, in case of asthma or COPD exacerbation, because of auto PEEP and lung over distension, it mimics the IVC distension and absent variation, even if patient is hypovolemic. Same happens in a case of certain cardiac condition like chronic RV failure, severe TR, RV myocardial infarction, as well as in patients having intra-abdominal hypertension. And the most important factor is the technical factor, that is the placement of your M mode, right? Even the probe angle errors may lead to the false IVC changes and measurement inaccuracies. So how to use POCUS for fluid status in current era? We should not overly rely on the IVC diameter alone. We should always incorporate the findings of the cardiac ultrasound as well as lung ultrasound along with the IVC. I am not telling that the IVC is useless, but yes, you should incorporate the cardiac and lung ultrasound finding while interpreting the results of the IVC. We should incorporate the mitral inflow pattern, E/A ratio, E by E prime. We should also look for the LVOT VTI. We should also check for the lung ultrasound for the presence or absence of B lines. And nowadays, we should also make a habit of looking for the organ congestion with the help of a Vexus. Another important topic is the cautions in the interpretation of B lines. So by definition, B lines are the vertical laser-like lines that emerges from the pleural line that reach to the bottom of the screen without fading, right? So what is B line? Basically, B lines denotes deaeration. That deaeration could be because of fluid, could be because of infection, could be because of inflammation, or could be because of fibrosis. So we need to differentiate between the different kind of B lines, right? As in the first video, we can see it is associated with a yes. Associated, if the B lines is associated with the adequate lung sliding, with shining pleural line, the probability of pulmonary edema is high. On the other hand, if B lines are associated with reduced or absent lung sliding, or having the thickened pleural line with typical subpleural consolidation with spared area, it suggests the inflammatory B profile, right? Next important thing is so a pointer slide change. So next important thing is we need to examine the whole lung, right? You examine the all 6 zones on both the sides. If the anterior zones are relatively clear as compared to lateral zone and more denser finding on the posterior zones, it denotes the gravity dependent distribution. And if such distribution is symmetrical in the both the side, it is the bilateral symmetrical gravity dependent distribution of the B lines that favors the diagnosis of cardiogenic pulmonary edema. On the other hand, if the B lines are associated with reduced lung sliding, irregular pleural line, more B lines on the anterior zone, lesser on the lateral zone, again denser on the posterior zone, non-homogeneous distribution, it favors the diagnosis of inflammatory or infective B lines. Next. Back. Yes. So we need to differentiate the various B lines, Z line and E lines also, right? What are the Z lines basically? By definition, B line should reach to the base of the screen. If it is not reaching up to the base of the screen, you may find certain presence of the A line as well. They are Z line because of the artifacts related to their probe positioning. Similarly, if B lines are originating from the skin and subcutaneous tissue, it is irregular pleural line. They are emerging from the different levels. It suggests the presence of subcutaneous air in case of surgical emphysema, right? Now another important topic is infection prevention and the patient safety. There are potential infection control risks are associated with ultrasound equipments. And various studies have shown that the ultrasound probes and gel can act as a vector for cross-infection. Even the transmission of various pathogens has been identified in the literature along with the contaminated probes and gels. So invasive and semi-critical procedures which carry the high infection risks if we do not follow the proper asepsis precautions. Next. So our goal should be to ensure the diagnostic benefit without compromising patient safety. Next. So we should always think for probe hygiene along with the hand hygiene in our day-to-day ICU round. Okay. So this American Institute of Ultrasound Medicine has released the guideline on cleaning of the transducer probe, its preparation and for its cleaning. And what is suggested, the routine ICU ultrasound, what we do, particularly cardiac ultrasound, lung ultrasound, fast examination, that requires only low-level disinfection, right? Next. So what is low-level disinfection? Basically, we should clean our probe if possible, with the manufacturer's approved clinic agent, you may check your prescription guide or your manufacturer guide. It suggests what type of clinic agent you should use to clean your probe. Next is, if it is not available, majority of manufacturers recommend the quaternary ammonium compounds wipes. But if it is not available, we should simply clean it with a soap water or detergent wipe. We should not use alcohol-containing clinical agents, particularly sterilium, what we routinely use in our ICU practice. Why? Because the alcohol damages probe lenses and adhesives. So it will shorten the lifespan of your probe. And we all know the cost of the probe, right? So practically what we should do, we should clean our probe with a gauze piece or tissue paper in between the patient. And at the end of a day or end of your round, we should clean our probe with a soft water or detergent wipe. That will prevent the cross-infection. Now next is the cautions in ONSD assessment. Nowadays, there is increasing utilization of ONSD for measurement of non-invasive intracranial pressure monitoring, right? Next. So this article published in Journal of Ultrasound Medicine raised the safety consideration for the diagnostic ultrasound in eye, because the ocular structures, especially lens and retina, are sensitive and have limited heat dissipation and making them particularly vulnerable to thermal damage. So ocular tissue is extremely sensitive to ultrasound energy, and we should monitor output indices that are thermal index and mechanical index. So how to monitor this TI and MI? So whenever you do any ultrasound examination, on the machine screen, you will find these two options, MI and TI. TIS means thermal index for soft tissue. So always monitor these two values. Properly select the preset. Most ultrasound machine, modern machines have a separate preset for the ocular ultrasound or ophthalmic preset or ocular preset. So basically, you need to monitor the TI and MI value. What is TI, what is MI, what is Alara principle? Basically, TI is a thermal index, is an estimate of potential temperature rise in tissue due to ultrasound energy, and we should keep the TI less than 1, preferably less than 0.5 for ocular application. Even various guidelines emphasize no ophthalmic ultrasound exposure should exceed TI of more than 1. Even the mechanical index it quantifies the potential for mechanical bioeffects, particularly cavitation formation, formation of microbubbles, and acoustic radiation forces. And various guidelines recommend MI of only less than 0.23 for ocular application. For other examinations, the limit is around 1.5 to 1.9. But for ocular, the limit is only 0.23. And we should always follow the LRA principle for ocular examination. As low as reasonably achievable, we should try to minimize the acoustic power as well as the exposure time. So now the term focus stewardship has been raised or coined by the Sokokui and colleague. They introduced the 4 components. First and foremost is the optimize clinical indications, right? So avoid scan hunting. Do not do haphazard scannings. What is your clinical question? And focus on a clear question. Targeted use enhances the yields, it prevents the overdiagnosis and false positiveness. Another important thing is assess for the pre-test probabilities. Consider how likely the disease is before scanning based on the history, examination, and the risk factors, and recognize the disease spectrum. Understand that the test accuracy varies with the disease stage and severity. The best example is the FAST, E-FAST. If you do the E-FAST immediately following trauma, the chances of false negative scan is quite high. But if the suspicion is high, patient is hypotensive, HB is falling, we should always repeat our scan, right? And next is the know the diagnostic accuracy. Next. So focus should complement, not replace the clinical reasoning and pre-test assessment. Next. Another important topic is focus documentation. This paper is published by Royal College of Emergency Medicine on the documentation quality of our focus findings. And they suggested we should document our focus finding under 5 headings, that is patient detail, indication, findings, conclusion, and sign. Next. So in short, we can write in our note also, for if example, if we are using POCUS for the cause to know the different causes of hypoxia, we should mention the POCUS was performed to know the cause of hypoxia. Cardiac and lung ultrasound findings show severely reduced LV systolic function with bilateral gravity-dependent B lines suggest possibility of cardiogenic pulmonary edema. Next, and the biggest and the last caution is PCPNDT. The machine, facility, and the intensivist or doctor performing the POCUS must be registered under the PCPNDT with the local appropriate authority. Ensure the presence of a female staff or attendant during the POCUS examination on a female patient, and clearly document the clinical indication for performing the POCUS. So, clinical pulse include, it is a clinical tool, not a diagnostic crutch. Interpret cautiously, avoid cognitive traps. Do not overly rely on the IVC. Not all B lines indicate fluid overload. Always follow appropriate probe disinfection protocols and follow the POCUS stewardship that suggests the right scan, right patient, right time approach. And still, despite knowing all the limitation, I strongly believe that the POCUS remains one of the most powerful and indispensable tool in ICU clinical decision making. Thank you.
Thank you, Dr. Rachit. And I believe gradually the USG probe is replacing our age-old stethoscope. And now it has become like nearly, 100%, knowledge is required as far as POCUS is concerned. Everybody should learn POCUS, right? Thank you so much. So now we go to our next speaker.
So our next speaker is Dr. Abhishek Prajapati. He's from same institute, Karamsad. He's a chest and critical care specialist at Sri Krishna Hospital, Baikaka University, Karamsad. And he's expert in USG, medical fluoroscopy, sepsis, extracorporeal therapy. He's a dear colleague of mine, and I think I've done a chest conference at Karamsad under his leadership. So over to you, Abhishek.
So thank you, Chairperson.